From the Journal of Nuclear Cardiology, this is JNC Cardio Connect, linking experts, insights, and innovations in nuclear cardiology. Let's dive into the next episode.
Welcome back to JNC Cardio Connect. I am Marcelo Di Carli. I'm the editor-in-chief of the Journal of Nuclear Cardiology. And today we're going to dive into an interesting conversation regarding training in cardiovascular imaging. Cardiovascular imaging is evolving at an extraordinary pace. We have new technologies, new clinical applications, and new expectations are reshaping what it means to be an imager today. Yet for decades, training and certification have largely evolved in silos: CT, echo, nuclear, MRI, with surprisingly little crosstalk between these opportunities. Now, at the same time, the newer generations of trainees are asking a different question. They're not asking which modality should I choose, but instead they're asking, how do I build a skill set that prepares me for a rapidly changing clinical and research environment, one where fluency across multiple imaging modalities is essential to remain competitive? So how do we reconcile a siloed training legacy with a multimodality future? How does modern cardiovascular imaging training need to look like? And how do we prepare trainees for careers that will demand integration, adaptability, and cross-disciplinary expertise? So today's conversation centers on a new training statement on advanced cardiovascular imaging, sponsored by the American College of Cardiology and developed collaboratively across all the major subspecialty imaging societies. This document doesn't just update procedural numbers, but it really challenges us to rethink how we train imagers in the future. So I'm delighted to be joined by Dr. Ron Blankstein, one of the co-chairs of the training document and himself a multimodality imager and program director at Brigham and Women's Hospital, and Dr. Larry Phillips, who is immediate past president of the American Society of Nuclear Cardiology and director of nuclear cardiology at NYU Langone Medical Center. We're going to explore what this statement means for trainees, for program directors, and for the future of cardiovascular imaging and nuclear cardiology in particular. So let's dive in. Welcome to both of you to this episode of JNC Cardio Connect. So Ron, we're going to start with you, and we're going to ask you to help frame for our listeners, what is the scope of this document and how does it define an advanced multimodality cardiovascular imager? And while you're describing the scope, we would like you to also emphasize how should we be thinking about COCATs in this new framework?
Great. Well, Marcelo, first, thank you very much for having me on the podcast. So when we think about this this document is really the blueprint for perhaps a new type of trainee, relatively new, and that is the advanced multimodality cardiovascular imager. So that is a person who's obtained the competency to perform and interpret all four main imaging modality: cardiovascular CT, cardiovascular MR, echocardiography, and nuclear cardiology. And that skill to perform and interpret is analogous to what we used to call level 2 in COCATs. Importantly, this is kind of the minimum skill set that you need. This is kind of the floor, I like to say, not the ceiling. But the key recognition here is that an individual who's trained in all four modalities will have special expertise because there's a lot of synergy between the modalities. Training in any one modality will give you certain skills that are going to be helpful when you interpret another modality. And of course, to integrate information from multiple tests is such a critical skill. And that's something that's also emphasized in this document. So that's kind of what we used to call level two. But to answer your question about advanced imaging and what we used to call level three in COCATs, this document also provides the competency, that is the knowledge and the skills, for those who choose to specialize in any one area, and that could be one or more areas. And that's more analogous to what we used to call level three, the person who has advanced expertise in the modality who can run a lab. I would emphasize that we're actually trying to get away from those categories of COCATS level two and level three. And I think people sometimes get so into the details. And it's so important to understand that what we are really trying to emphasize is competency, which is your knowledge and your skills, in really trying to move away from those old COCATS terminologies, which focused a lot on numbers.
Thank you, Ron. Very important document and interesting to read. So, Larry, we'll turn to you now. Just tell me what stood out to you as the most important changes on training implications for nuclear cardiology.
Absolutely, Marcelo, and thanks for the invitation to be on the podcast as well. I think that these new imaging statements really show the evolution of multimodality imaging, and specifically in nuclear cardiology, it shows the changes that have taken place since the COCATs were published last in 2015 for nuclear cardiology. I think we see the evolution of technology. So we see the movement from standard SPECT to solid state detectors, a lot more emphasis on cardiac PET and all the applications there, and a real desire to push to the trainee the need to have a comprehensive educational experience. And that projects through the entire document. I think it also breaks down silos of the imaging modalities. So instead of looking at one alone throughout the paper, it really is looking at all of the imaging approaches and showing how they have importance in being viewed together and making sure the right indications for a particular test are there. So I think it ends up being very important across the board. It also make sure that when somebody is looking to train in advanced imaging, that they are learning about all four of the modalities. And many times with a focus in one, they might lose another imaging modality completely. And this shows the importance of that comprehensive training.
That's right. We're moving into disease-centered approaches to imaging. So I think what you highlighted resonates with me as well, that while people may choose to be a specialist in one area, they really need to be more than conversational on the other areas, because sometimes the best technique might not be the one that you're an expert on. So in order to guide people, I think that would be important. Now, I'm going to ask a question to both of you. We keep talking about AI has invaded every aspect of what we do in our imaging practices. And so the question is, what are the implications of that? What is AI literacy, and what does that imply for the training of the future generations in cardiovascular imaging? And I'm going to ask Ron, why don't you go first, and then Larry, you can chime in.
Yeah, no, it's such an important question and an area that keeps on evolving. But I think there are probably more uses of AI, at least in cardiology and imaging, than there are in other areas. So it's an area that we're seeing probably some of the biggest advances in AI, and they range from scan acquisition to processing to interpretation. But there are important limitations, and when we send data, and regardless of the modality, to some sort of AI analysis, it's really important to know when we get that data back to be able to do some kind of quality control. There always has to be a human in the loop. We cannot assume that a computer does an analysis is going to give a correct analysis. So you always have to understand what are the quality control, what is the way to kind of vet the data to make sure that the analysis was performed accurately. And then does it really apply to the population that we're trying to apply it to? So if AI, we know this all very well, that if AI was validated and derived in one population, we're trying to apply it to patients who are different, the results may not be appropriate. So really trying to understand the limitations is so important. We can't just treat AI as a black box that give us data and assume that that data is correct. So a lot of opportunities, but then there's now a lot for us to learn, both about the model validation, about how to apply the model correctly to our patients.
And I agree completely about the idea that AI often is viewed as a black box, especially imaging. You see a set of images, you haven't learned how the image actually was processed to get the product that somebody's looking at. And so I think for AI literacy in training, it's going to be teaching people how the image got from A to B, how it came from acquisition to what you're actually visualizing and actually using for your interpretation, the roadblocks, the errors, the quality that Ron talked about. And I also think that we're going to see more and more similar to the way we have journal clubs for research articles. We're going to be teaching our trainees how to analyze what AI algorithms are used and how to validate it and make sure that it was performed in a way that's beneficial when we're doing training and interpretation going forward.
So, really great points by both of you. A human needs to be in the loop. We're not ready to replace humans with a machine. So now, Ron, I'm going to turn back to you. Many people want to train in multimodality imaging, but the question is, how accessible are these training opportunities today? And where do you see the biggest barriers for accessing training programs on multimodality imaging?
So it's a really good question about access to training programs. And the good news is that there are now more training programs. When we started this at the Brigham, at least a while back, we were one of the early programs that offered a 2-year opportunity to train in all modalities. There's now more and more such programs. But the reality is, if you look at programs today, there's a huge variability. There's programs that are 1-year programs that offer training in any one modality. Then there's some 1-year programs that may offer training in 2 modalities. But my recommendation to anyone listening who wants to be an advanced multimodality imager, as outlined in this document, is you really have to invest the time, and that will almost always be a 2-year fellowship if you want to train in all the modalities.
Fantastic. So while we are on the topic, this raises, as you mentioned, a lot of questions for some of the programs. What happens if you don't have access to every modality in your own program? What can programs and trainees turn to for support? And, what are societies doing to fill the vacuum? Larry, maybe we'll start with you. You mentioned that the document highlights the increasing role of PET, for example, in nuclear cardiology. So the question is, not every program has that. And so what is ASNC doing to help out to fill this vacuum?
Yeah, I think that the new training guidelines comes out at a great time for ASNC. Over the last couple of years, we've been asking that question for the comprehensive cardiology training for 3-year training programs, what the nuclear cardiology education should look like, and making sure to build programming initially in didactics, but now in case-based learning for all the different areas of nuclear cardiology. So the PET component of it, but also, as you mentioned earlier, the disease state. Now, with the new guideline looking at the advanced imager, we know that we need to expand on the educational resources that are available. And so we're planning to have both didactic and case-based learning to support all trainees in advanced imaging, but specifically to make sure that it's of the breadth needed for some of the programs that might not have all the techniques available. And we think that we'll be able to have that as we look at the aspirational component of this training document, that we'll be able to support so that everybody anywhere training in advanced imaging will be able to have that foundation of nuclear cardiology independent of what their program currently has.
Ron, are you aware about what other societies might be doing to fill this apparent vacuum in multimodality training?
Yeah, it's a really important question because the document as written states various skills are required that many programs don't have, and this is across all the modalities. In every single modality, there may be certain skills that an institution doesn't have. Doesn't mean it's a bad institution or that it can't train people, but it does mean that those trainees have to get those skills elsewhere. And very much when we wrote the document, we recognized that in the current era, the skills that a trainee attains are not just going to occur at the program. There are going to be virtual opportunities. There are going to be courses. There's going to be other ways, specifically for some of the more niche things. So When we talk about nuclear cardiology, for example, quantifying myocardial blood flow with PET or looking at viability imaging or sarcoid imaging are all kind of more niche skill set that some programs may not have. For every imaging modality, the societies are all thinking about what are the areas that are going to be very challenging for trainees to attain and how can we offer that. And importantly, offering that doesn't mean a PowerPoint or a podcast. I'll say that because we're on a podcast. It really has to be a hands-on experience. It has to be a trainee interacting with the data with a virtual workstation. There are classrooms that are developed. The ACC is actually developing now a classroom with computers that they will have hands-on courses that trainees can come in and actually walk through cases on virtual workstations. So I think it's important for all our societies to develop the right content, the virtual content, whether that is a live content or whether that's on demand content that trainees can do off hours. The key is that this has to be done in a thoughtful way and try to, as much as possible, simulate real world experiences of reading a case.
Fantastic. Thank you for the wealth of information provided by both of you. And so now to maybe the final question is we still have 3 years of internal medicine, 3 years of cardiology, and then we're adding 2 years of cardiovascular imaging. Is this sustainable?
So I think there needs to be pathways that make it easier. Certainly, there are going to continue to be individuals who do 3 years of cardiology and then 2 years of imaging, and there's nothing wrong with that pathway. But for programs to really attract good applicants, they may want to be more innovative. So, for example, there could be a 2+2 pathway where trainees spend 2 years focusing on general cardiology and then 2 years after that doing imaging. The same thing, of course, exists for EP and cath for training pathways. Or even to start focusing on imaging skill sets even during those first 2 years. So trainees who are interested in multimodality imaging in the right programs, some of those trainees can start getting more experience even earlier on. I can even envision, rather than 2+2, a 4-year fellowship where a trainee who gets more exposure to imaging can fulfill many of these competencies in 4 years. So I think we have to be innovative and think about how we can integrate this into existing training program and make it in a way that's appealing for our trainees. After all, we do need more imagers. There is a big shortage. So I think it calls on all of us to make this more doable and more practical.
Yeah, and I think that for the advanced imager, programs looking at the 2+2 approach is going to be very important. I think that, as Ron mentioned, we're seeing that in multiple subspecialty areas, and I think that the training program of the future for comprehensive cardiology, that 3-year training program, is going to evolve in that direction. I think for many of the people listening also who are thinking, does that mean that if I want to be reading an imaging modality that I'm adding extra years to my training? I don't think that this document says that. And I think that that's important. I look at that focus being the evolution of the imaging and showing that we're going to be changing the way we teach the trainee about imaging, disease state analysis, but that this really focuses, when thinking about the duration of training, on somebody who is the true advanced imaging professional.
Yeah, and I think that's a really good point, Larry. And I would kind of emphasize that while this document deals with folks who want to train in multimodality imaging, there's plenty of individuals who, as part of their general cardiology fellowship, may choose to train only in nuclear cardiology or only in echo, which of course is possible. You certainly will not be a multimodality imager, or by this document, you won't be an advanced multimodality imager, but you certainly can be still advanced in one modality. And that is also a career possibility and a pathway. So important to emphasize that.
Okay, so this is a great point on which we can end our brief conversation. I really thank both of you for a very thoughtful discussion. I think this document, as I reflect on it, is not just about requirements, that's obviously a part of it, but it's more about challenges on how to rethink the future of training. And as you elaborated over this discussion, there are multiple ways in which people can choose to focus their training. Some of them will choose a single modality, but more people are choosing to becoming multimodality imagers. So I think the document is a really great resource to start a conversation. By no means, I think, is the end of the conversation, but it's the starting point. I know, Ron, that you are preparing a session at the upcoming ACC in March that will dive into these very questions that we have been talking about. And I encourage our listeners that are attending the ACC to make it to that session because I think it has implications for all the imaging subspecialties. So again, thank you very much to both of you for spending time with me here. Thanks to all of you for listening to JNC Cardio Connect. And until the next episode, thank you.
Thank you.
Thank you so much.